Orders. Thank you very much. In Psychopharmacology Congress, I just wanted to thank for giving this opportunity to discuss psychotherapy options. Indeed, Serhat stated BDT instead of PDT, so there was a confusion, but I believe in a short time you expressed lots of things. So I will be talking about psychodynamic as PDT. And in Serhat, he stated that there is no golden standard, but what a coincidence, I started with golden standards in cognitive behavioral therapy. It is somehow thought as cognitive behavioral therapy, it is like a ghost, and there are some criticisms for that ghost. What is CBT? CBT is Psychological Science-Based Progressive Psychotherapy Research Program. It is not a static thing, but it is a progressive use of science in psychotherapy. There is no need to, if we have to call something as golden standard, CBT is golden standard. Why? Because CBT is the most researched form of psychotherapy, and there are psychodynamic studies as well. But in terms of number of studies, the size of the studies, and for the efficacy and efficiency, it is the golden standard and no other form of psychotherapy. Yes, there could be some studies showing the similar efficacy, but CBT is better. If something is shown as superior, then it is superior. And the most important part is the CBT theoretical models, mechanisms of change have been the most researched. In PDT, we do not have that much scientific studies. And then again, there is clearly room for further improvement in for CBT. Other therapies, it seems like they are mostly static. They apply it in the same way all the time. All those therapies are improving through the years because there is a revision together with the scientific studies in CBT. And stages of development of scientifically based psychotherapy. Clinical observations are made here, and to create assumptions based on a theory connected to scientific psychology, there is a positive paradigm here. If you try to create a scientifically based psychotherapy, first we start with observations in depression patients, and then upon those observations, in which field you had them, the perception, thinking, and the observation. And together with those observations, you create your hypothesis. For example, depressed patients, when we check their lives, there are some negative effects, and the awards, for example, there is an increase, and their perception for negative events are higher, and they do see their environment negatively, and then you create your concept. With that, of course, you include other groups to validate your hypothesis, and if it is valid, then you prepare some interventions, and with those interventions you test them, and with the results of the test you create a treatment package, and with open studies and after randomized studies with different research centers and with different groups, multiple centers are included to have repetitive studies in the area to replicate your results. Between 1967 and 1985, there were 220 studies. For 19 studies supporting the assumption of negative bias in perception, it supports the idea, and there were 150 studies supporting the cognitive triad theory of depression. The assumption that there are dysfunctional beliefs in depressive patients was supported in 31 studies, and 6 studies did not support. So with psychopathology in cognitive or in behavioral levels, why there is a depression, we may give some answers together with those studies. And Serhat highlighted the point of efficacy especially, and right at that point PDT has lots of studies. Why? Because it starts with a scientific program. In order to test something, in order to test a psychotherapy test, then all psychotherapists need to perform the same thing, and that should be something concrete, something very clear. If Ahmed does something, Mehmet does something different, then we can't claim that the thing that we do perform is effective. But no, it is not the idea. Everyone should perform the same protocol. And through the years, PDT started as a manual study, so it could be tested, of course. And psychotherapist has this rejection. They stated that there is no static feature of this treatment, and you can't test it. And insurance companies, for example, they supported BDT, but they didn't cover BDT, but they do cover the psychodynamic treatment costs, etc. Those are all debatable, and the results are coming from Netherlands in majority, and Serhat most probably you also realize that, but there is a focus in Netherlands for that study, and in those studies, the details, the evil is hidden in details. In 2017, there is another Dutch study. BDT and PDT is compared directly, and behavioral treatment includes females in majority. And for PDT, majority of them are psychiatrists and male. This is a fault in terms of a randomized controlled study, because for BDT performance, they had some analysis. For example, 8 out of 10. But for PDT, there is no liability scoring for that, but there was for BDT. And right at this point, when we check the meta-analysis, there is a 2013 meta-analysis, 0.70 is the effect size. This means that if you provide some treatment to a group, they are in a better position, 70% when compared with the placebo group. There should be a hypothesis, the testing of hypothesis, randomized control studies. We have stated that. So in terms of evidence level, the reviews and meta-analysis in the top of it, systematic reviews, then randomized control studies, cohort studies, single case designs, case studies, and expert opinions at the bottom of the thing. So we need to think about this event first. The effectiveness of psychotherapy. Psychotherapy's effectiveness does not mean that it is effective for just one reason. All psychotherapies could be gathered in one pool, and an average untreated person, an average psychotherapy client, nearly 80% of them, the treated ones, are giving better outcomes. It is somehow like the dodo bird effect, but that person said this in 1936. the things compared at that time is psychoanalysis variants. In 1972, there is another one supporting this idea, and behavioral therapies and non-behavioral therapies are compared. And in behavioral therapies, there is also cognitive treatment, so included in that. So when we check the details, the thing that we would like to see could be found in literature. However, when we check the literature and the methods of the studies, it is completely different at that point. And why can ineffective therapies appear to be helpful? Why? Because there is a spontaneous remission. People could get better on their own. There are some ups and downs in the life. And the second thing, psychotherapy has a placebo effect. When a person listens to you, hears you, understands you, it gives some positive effect on you, and you create a trust relationship. And the third thing is self-serving biases. The person believes that there will be a benefit from that psychotherapy. That's why they found it helpful. And the fourth thing is regression to the mean. Generally, those are in the worst case scenario clinically, 58 out of 63 the scoring. So whatever you do, there will be some help for that person. And the fifth thing is retrospective rewriting of the past. The effects of previous therapies could be reflected in psychotherapy, and Kemal knows that quite good indeed, because he has a book on that issue. And when we check the studies one by one, you may find lots of things. However, you need to have a critical approach for that, and then you need to have the outcomes. Society of Clinical Psychology in the United States, they try to classify evidence-based treatments in psychotherapy. And at the end of the 1990s, they have a study, and as a result of the study, this is a Division 12, and you can find it online quite easily. Chambliss et al. Established criteria for modest treatments and strong treatments based on type of study, number of studies, and how many people included, and a good, well-proven evidences. Well-established treatment criteria. At least two good between group design experiments demonstrating efficacy in one or more of the following ways: superior to pill or psychological placebo, or to another treatment. Or the second thing, equivalent to an already established treatment in experiments. The second option, a large series of single case design experiments demonstrating efficacy, and these experiments must have a good experimental design, and those should be shown in active ways. And in both options, treatment manuals or equivalent clear descriptions of treatment should be seen, and the characteristics of client samples must be clearly specified. Effects must have been demonstrated by at least two different investigators or teams, and just one team is not enough at that point. And probably efficacious treatment, when we come to this point, as I had stated, the quality, low quality studies, wait lists, for example, show some superiority, and those are accepted as low quality studies. And for psychological treatments, which are listed as effective on depression, by saying effective, the level of evidence is examined and it is updated in this guideline. The acceptance and commitment therapy for depression, they have average evidences for that, behavioral activation for depression, CBOSPs, cognitive treatment, there is a strong research focus, emotion focus therapy for depression. Interpersonal has good evidences, strong evidences, and problem-solving therapy has strong evidences as well. From this point of view, the psychodynamic therapy, which is investigated, researched, and this is the manualized way of it. There is the medium levels as evidences, and for panic disorders, you may see strong evidence is available. For psychoanalytic treatment, medium evidences are available, modest evidences are available, and it is open to discussion. For APA depression guideline, when we check it, the latest upper guideline, depression-focused psychotherapies include cognitive behavioral therapy, interpersonal and problem-solving therapy. Psychodynamic psychotherapy is an alternative option. In 2017 guideline, there were no statement for psychodynamic psychotherapy, so in the latest one, it is stated as an alternative. When we check the UK guideline, they have stepped care model. And at this point, it is not for being mean, but for not believing the efficacy. There is no psychotherapy involved in the first stage, but some psychosocial interventions could be made in low intensity. What are those? Self-help, but with BDT principle-based helps are included there, and also exercises recommended. For moderate or severe depression treatment, UK recommends medical treatment, and high-intensity psychological intervention is included. Cognitive behavioral treatment or IBT is recommended. And for preventing relapses, Level 2 evidence is given for individual CBT and mindfulness-based cognitive therapy, which is also scientifically based psychotherapy. It is to prevent any relapses. To summarize all, in major depression, there are acceptable things for CBT. In recent meta-analysis indicates that psychotherapy is preferred 1 out of 3 to pharmacotherapy, and it is cost-effective. And for the relapses, there is a decrease with BDTs. For unipolar depression, when we compare them here for CBT and other psychotherapies, behavioral activation is quite effective, as well as cognitive therapy, and whether CBT differs from focus dynamic therapy or supportive therapy depends on the scientific studies included in meta-analysis. So Serhat presented some studies which shows there is an equality in between the treatment phase, but the most important thing is for moderate to severe depression. There is only a comparison between the medical treatment and the CBT treatment. And there's placebo group, so the psychotherapy is found as effective as medical treatment. This is 2016 meta-analysis data. This is the latest version that I could have found. Pulpers published this, and he just performs the meta-analysis, and he is quite good in statistical data. As a result, all controlled studies, those are not weightless, but controlled studies, 0.75 greatness in terms of effect size.
This is a continuum of the research that I have shown. 1 year after the treatment has been withdrawn. So when you stop the antidepressant and continue with placebo, in 70% of the patients, there's recurrence. On the other hand, around 70% of the patients who were given cognitive behavioral therapy sustained the positive effects of treatment, and if medicine continues, then the protection level is almost the same like CBT, and the recurrence rate is high. For the prevention of relapse, there are 7 studies carried out, and according to this, compared to placebo, 61% of protection from relapses is provided by CBT. So you give CBT to the patient, and for 2 or 3 sessions, you give reinforcement, and then there is less recurrence by 61%. It is the same for behavioral activation. CBT for medication-resistant depression, there are 19 patients in one study carried out, and there is 63% remission rate and maintained for 2 years in 83% of the patients. Another study, a different protocol, CBT for prevention of recurrent depression. 40 recovered patients are given CBT and clinical management. During the same time, they are given support interviews, clinical management. And the person on CBT group has 25% relapse rate at 2 years, and clinical management group 80%. Then 60 relapse rates were published, 40% for CBT group and 90% for clinical management group. So the rate is increasing with the passing of years. Ratings of therapeutic alliance. We know that CBT is superior to psychodynamic interpersonal treatment according to the patients. It's as if Mr. Spike it's like talking only about logic, and back in 1979 devoted a chapter of his book to emotion. So it's like a cartoon of CBT, and there's actually a political type of criticism there. I believe he's Marxist. It's not for judging. His criticism is still very valuable, but he has a political perspective actually, and also criticizes medicine as a whole, or criticizes positivist paradigm as a whole. Behavioral activation, problem solving, and about anxiety disorders, the superiority is more meaningful. 0.88 for CBT, you can see IE plus CR. These are the meta-analytic results of panic disorder treatment studies. Compared to benzodiazepines, SSRI, it's more effective. And the APA guidelines are shown here. It shows that there is convincing evidence here that supports cognitive behavioral therapy. These you can see here, 0.81 of difference for panic rather than depression. In panic it's better. The NICE guideline. Here it says in panic disorder, psychological, psychopharmacological or combinations are effective, and CBT is more effective than tricyclics. Yes, it's effective, of course, but in the study environment, in randomized controlled studies, therapists are being trained and supervised, so maybe the results may be more positive. However, in the UK, cognitive behavioral treatment, CBT, is in primary care, and it can be learned and practiced by clinicians at primary care. And 24 comparisons of CBT to a control condition. It's a meta-analysis from 2009 and shown to be superior. Meta-analysis from 2016, size of effectiveness, as you can see, about 0.80. Conclusions now. CBT is an effective and tolerable treatment for social phobia. This is what we believe. And for generalized anxiety disorder from the Cochrane database, let me show you the studies. There are 22 studies including more than 1,300 patients. And here, based on the 13 studies, psychological therapies, all using a CBT approach, were more effective. So, psychological therapy based on CBT principles is effective in reducing anxiety symptoms. And this also shows the meta-analysis for generalized anxiety disorders. The size of its effect is 0.81, you can see. Treatment acceptability. In panic disorder, social anxiety, the results seem similar. In generalized anxiety, OCD, post-traumatic stress disorder, looking at the dropout rates, in CBT compared to others seems to be more acceptable. Here you can see different anxiety disorders, PTSD particularly. In this you can see a very important effect size around 2.5. So as a conclusion I can say that modern CBT is an umbrella term. And the psychopathologies that are underlying should be clearly defined, and then they should be targeted with specific treatment strategies. This is like a research program doing all of this. And CBT has currently included a more transdiagnostic and process-based and personalized approach. And this way, the interventions of CBT are more personalized, and generally the behaviors are being analyzed, and here it has become a type of therapy. Actually, Mahoney is the founder of CBT. I'm quoting from him. He made some criticisms of CBT actually, and it is more related to understanding and practice rather than the method when we hear the criticisms. So it's not about the technique, but how you implement, which can make a difference or be criticized. Many CBTs, most psychotherapies actually, do not come close to the numbers in terms of the active status of the comparator and the study quality so far. And CBT is evolving continuously based on the cumulative and critical research and integrated into a larger framework. And of course, if a therapy claims to be evidence-based, then there is always room for improvement. CBT is the same. there's still room for improvement. There may still be patients who do not respond to CBT or have relapse, and studies on these patients continue. And while many non-CBT psychotherapies have changed very little in practice, always the same methods are applied since their creation, CBT is continuously evolving based on research and data, evidence. So we hope that in future continuous improvements in psychotherapy will derive from CBT and gradually move the field towards an integrative scientific psychotherapy. This is my expectation. Thank you very much.